We're doing KDHE recommendations today.
Okay, no problem, Mr. Chair. We would like to add language to pay hospitals and physicians at the Medicaid rate that was established in FY 2021 until the first calendar quarter following approval by CMS Committee for Medicaid and Medicare Services provider assessment rate adjustment as recommended by the 2019 legislature and amended by the 2020 legislature.
Do I have a second? Second by Representative Vaughn. Discussion. Just as a little backdrop.
Shall I establish? So
yeah, go ahead.
I'll give you a little more information so you'll say, okay, so what does that mean? Okay, especially for our brand new people. Number one, the 2020 legislature appropriated $14.2 million to cover FY 2020 shortfalls in the program while waiting on CMS approval of the program changes to make the program self-sustaining. The program overspend for FY 2020 was $8.4 million. The remaining $5.8 million was swept in caseload adjustments. The goal is to get the program approved by CMS by July 1, 2021. Remember, July 1 is when we start our new fiscal budget. To help us continue the program without cuts until we get CMS approval, we need the following. We need language in the budget bill directing KDHE to pay hospitals and physicians at the Medicaid rate that was established in 2020. And that would be until the first calendar quarter, which means the 3 months, following approval by CMS of the HCAIP hospital provider rate as approved by the 2020 legislature, which we've actually approved. We're going back to that until we can get what we need. And this would apply to FY 2021 and FY 2022. Allow any shortfall to continue to be covered in caseloads until the program updates can be implemented following CMS approval. Okay.
Very good. Do I have a second? Representative Helmer. Discussion? I'll clarify just a little bit. Last year we passed the HCAP bill that allowed the hospitals and providers to raise the rate from 1.3 to 3%, and also to change that to now it's just inpatient, and we changed it to raise it to inpatient and outpatient. And it will raise, I'm not sure what the budget deal, but last year it was raised over $300 million and brought back to our local hospitals and providers. So CMS, in this whole time, we've been waiting for them to approve the 3% raise. They have not, and so we're still at the 1.83 rate, and will be until, and that's what this says, until they raise, till CMS raises it to 3%, we will be at the current rate of inpatients at 1.83%. And it brings back down about $110 million. So, all right, any clarifications?
Good. All right.
Okay, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Do I have any further committee recommendations? Representative Vaughn.
Mr. Chair, I would like to recommend that we add $2 million all SGF for primary health projects for community-based primary care grants for fiscal year 2022. In addition, add language that this amount is to be directed to community-based primary care grants provided by the Community Care Network of Kansas.
Very good. Do I have a second? Second by Representative Ruiz. Discussion? I think many of you know they came in, talked to us last year. Their money was allotted by the governor, and we're just replacing that money. So it's no more, no less. There was $2 million in there last year, and the governor allotted it, and we're just replacing that money. So, further discussion? Representative Helmer.
Chairman, I'd like to add $1 million all SGF to increase funds available to local health departments using the statutory formula distribution contained in KSA's.
Okay, hang on just a minute. We've got to vote on the other.
Oh, I'm sorry.
Okay, that's all right.
Wanted it-
I thought you were going to do some discussion. Okay, all in favor, say aye.
Aye.
Opposed, same sign. Motion carries. Representative Helmer.
Okay, thank you. Mr. Chairman, I'd like to just move or yeah, I'd like to add that we add $1 million all SGF to increase funds available to local health departments using the statutory formula distribution contained in KSA 65-242 for fiscal year 2022. And this will bring the amount available for distribution to the 100 Kansas local health departments using the formula to 3.2 million. Thank you, Mr.
Very
Chair.
good. Do I have a second? Representative Ballard, discussion? Committee, I think you remember them coming to us, and last year we had $900,000 in there that was allotted by the governor also, and this is just replacing those funds and another 100,000. So, further discussion? All in favor, say aye.
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 Opposed, same sign. Motion carries. Further, Representative Kincannon.
Thank you, Mr. Chair. I'd like to recommend that we add $150,000 all in SGF for the Kansas Trauma Program to sustain the program's statutory requirements to address the treatment and survival of critical injuries throughout the state for FY 2022. And
Go ahead.
I was just going to make a few comments about this. This is under KDHE, obviously, and the trauma program has a registry that's housed within the program for all hospitals, and just the maintenance and hosting of that is $175,000. So their ask was $300,000, and it was cut to $150,000. So I'm just asking for that $150,000 to be put back in. That costs $175,000. The remainder of the ask would provide for the operations and salaries of the 4 program employees. The program also offers the 6 trauma regions an annual budget to educate healthcare providers on the specific skills for trauma care. There's no federal grant money available for that, and it's very important to keep that education in there. So, thank you, Mr. Chair.
Did we have a second?
I'll second it.
Second by Representative Ballard. Further discussion? Seeing none, all in favor say aye.
Aye.
Opposed, same sign. Motion carries. Very good. Do we have any more committee recommendations? Representative Land.
Thank you, Mr. Chair. The committee recommends that information be gathered to provide a clear understanding of the following. 1, the process by which Kansas sets and adjusts the rates paid to the managed care organizations providing CanCare services. 2, the federal laws that guide the rate-setting process for states with managed care. And 3, information on how other states with Medicaid managed care set rates and whether there is legislative oversight of the process.
Very good. Do I have a second?
Yes.
Representative Ruiz. Discussion. Committee, I'll just volunteer. This is kind of my pet deal here. Last year, they handed me a $460 million bill for CanCare caseloads. And we're always behind on CanCare caseloads, and we do it twice a year. We do it in November and we do it in April. And we may have the best, quite frankly, we may have the best system there is out there, but we don't know that, and I certainly don't know that. And the other thing is there is no legislative oversight in CanCare caseloads. the KDHE folks meet with the MCOs, and then they do their deal, and then they give it to KLRD, and they do actuary, anyway, whatever. They do that, and then we get the bill. And there are other states, I've been after this for about, 6 months or a year, and the information I've been able to gather, there's other states, and probably the most important part is that there's a legislative oversight in that, where somebody from the legislature, I don't care who it is involved in that negotiation process. So this just starts the process to ensure, at the end of the day, they may come back and say, we're doing as good a job as we can on caseloads, but they really are a killer. Many states, as a matter of fact, just do it as a budget amendment. So if they get a caseload, instead of doing these caseloads that we figure, that just goes into the budget, and it's just an increase in KDHE of $100 million or KDADS or whatever. But we need to take a hard look at that to see what the problem is. So anyway, that's discussion on that. Okay, further discussion? All in favor, say aye.
Aye.
Opposed, same sign. Very good. I have a couple here. It's going to get fun now. Committee,
Let's go get one.
if you remember last week, we had testimony from KDHE about the budget shortfalls in the CHIPS program. CHIPS program has been going down. It's now at 71%. And with the increased EFMAP, it's like 75. But the bottom line is KDHE has been paying, their bill is $20 million more. Last year, they've added in their budget. They're probably going to absorb that through fees. They're paying it through a fee fund. But in 2022, their bill is $29 million. And they cannot absorb that. So with that, my motion is to add language to transfer $19 million all SGF, which is included in the governor's recommendation for Medicaid expansion, to partially fund the agency's enhanced request for the increased state share of Children's Health Insurance Program for 2022. If Medicaid expansion does not pass during the 21 legislative session. Do I have a second by Representative Kincannon. Discussion.
Just clarification. So we're saying this funding would come out of that money that's appropriated for Medicaid expansion. Okay, at that point.
If it does not pass.
If it does not pass.
Representative Reese.
I was trying to find how much was set aside for Medicaid expansion. It was like,
That was it, 19 million.
it was the 19, okay, so
That's what it was.
so you're moving the entire 19 million over.
Correct.
Okay.
Further discussion? Okay, seeing none. All in favor, say aye. Opposed, same sign. Motion carries. The second part of my motion is a cleanup, which has caused us some grief in the KDHE budget. I think you heard Megan say that. My motion last year in appropriations did not include removing the federal portion of that. So it was $549 million. And because my motion was not correct, we have $549 million in there. It's just a phantom figure that was left over when that line item was taken out last year. If you remember, last year's 17.5 went to the COVID relief fund, the $50 million COVID relief fund that we ended up when we left the session. So this year, I'm not going to make the same mistake twice and inflate that budget. It doesn't mean anything, but in fact, my motion will say, delete $577 million, all from special revenue funds for Medicaid expansion for 2022 if Medicaid expansion does not pass during the 2021 legislative session. The Budget Committee notes that KSA 39-609E2 requires Medicaid expansion to be approved by the legislature. So basically, it's just taking, it's a figure that's out there that Medicaid expansion, should it pass, would have cost the state $19 million, and the $577 million would have been federal money. So we're just wiping that line clean. Discussion? Representative Reeves.
Mr. Chair, I guess I'm confused as to why even do that. I don't
Well,
know what the purpose is.
Because if I don't remove it, it stays in the budget. If we don't statutorily remove that as a budget committee, it just sits in there. And then the next year, it's still sitting there, and it inflates our budget by $549 million, which means absolutely nothing, only the fact that I didn't make the motion correctly last year to remove both of them.
Okay.
So it's semantics. I mean, I'm not trying to pull anything, I'm just.
No, I was just
trying
trying to
not
understand
make
in
the
my
same
head
mistake
what that
twice.
meant. Okay, thank you.
It's kind of like a correcting journal entry.
Exactly, exactly. Representative Helmer.
Mr. Chairman, what's the statement that you're going to make?
Which one?
The one to correct it?
I just did.
Say it again. My ears are
Add
tired.
language to delete $577 million, all from special revenue funds for Medicaid expansion in 2022. If Medicaid expansion does not pass during the 2021 legislative session. The Budget Committee notes that KSA 39-709E2 requires Medicaid expansion to be approved by the legislature. Now, should Medicaid expansion be approved by the legislature, then it'll be a funding issue, and we'll deal with that when that happens.
Okay, thank you.
Very good. Further discussion? Seeing none, all in favor say aye. Opposed, same sign. Motion carries. Further committee recs. Representative Ballard.
Mine is a basic one. Do you remember last week we had a conversation where we were talking about dental care, especially with seniors and not being insured and along those lines? Well, I would like to just make a recommendation that we request an interim study on dental care for low-income and senior citizens in Kansas.
Very good. Do I have a second? Second by Representative Reeves. Discussion?
The only thing I would add to that is I think we heard from the conversation that especially in rural Kansas, we have a bigger problem with not having dental care. Dentists can cover a 400-mile radius. And remember, it took us over, or maybe you don't remember, over 3 years to find a dental director in the state. We have one now. We want to keep one. We've had one for 2 years, is what we were discussing. But, you know, one of the main reasons I want to do it is because of dental care, but because of how important dental care is to our overall health, period. We just think, you know, if you have bad dental health, you're going to have other kinds of problems as a result. And especially in the rural area where they don't have as much access to it and children don't have as much access. And so that was the main thing. But when I looked at it, and I thought, well, don't just limit it to seniors and don't just say rural. If we looked at how we are doing in the state for low income and seniors, we will get a true picture of what is happening as far as our dental care in this state.
Very good. Representative Kincannon.
Thank you, Mr. Chair. So tomorrow, I haven't seen, well, I think I saw the list of bills that will be on GO, and I think we might have somebody here that would know, but senior care task force bill is above the line. So that was on the list of one of the topics that, and with our issue, it would be focused on seniors, but dental care was one of the issues that I have on that to be discussed in that committee, that task force.
Okay, but does that have anything to,
No, I'm just adding that we're just on the same wavelength. I don't know that it makes a difference on your recommendation. I'm not trying to take that away in any way, just saying that
So
we're
it
going to,
is on there, and it should be because it's extremely important.
it's not in the bill, but it's on the list of topics.
Okay, good. Thank you very much.
Representative Donahoe.
There we go. So what was the motion again? I'm sorry. Was that the funded or what?
No, an interim study.
Okay.
An interim study. I should have made that clear for anyone who thinks it's funding, because funding, I'd have to give you a amount of money for that, but a senior study to look at the needs of dental care.
Okay. Thank you, Mr. Chair.
In committee, just refresh your memory, we did put some money in last year for dental, specific dental codes. $1.3 million, brought down about $3 million in federal funds to help attract dentists to take Medicaid patients. Unfortunately, as you heard in testimony the other day, COVID came. We don't have that measurement that we normally would have, because most dentist offices have literally been shut down. So I was pretty disappointed with that, but in fact, we just have to deal with it. Representative Donahoe.
Yeah, so let me go back to that. So when you say do a study, obviously we know there's a need for dental care. I mean, we pretty much agreed to that. So what would be the purpose of the study? I mean, do we direct them, look at this, look at that? What are we really going to be looking at?
Well, the purpose would be, this summer we did one on mental health reformation, and we divided into different groups. And part of an interim study is to really look at it and say, how many people do we think are in our state that actually need dental care that are seniors? And how many are receiving that? How many in low income? And how are they doing in that aspect? How many dental offices do we have that's available that will offer reduced rates or whatever? So it's a whole study looking at what it is, because we know it's not going well, but the only way you're going to improve it is to look at areas that may be really deficient, and that's where we focus on trying to give them the help that they need in that area. So you're kind of pinpointing what you want and how can you help it.
Right, and with that, do we get funding information, or do we have to request that? Because, as I said, I think we all agree, there's the need and everything, it's the funding. So where will we get that information?
Well, I think it depends on how we would structure the interim study. If they decide that this is an interim study that has to be, it has to be put out there, and either the governor then asks for it, just like she did mental health, or we can ask for it ourselves, and we just look at it in terms of what these areas are. And then I think you can look at what the funding would cost if we did this, or if the funding would cost if we did that, and pigeonhole which one. Because obviously we can't take on everything at any given time. So my preference would be that we look at seniors, because we know that they don't get insurance coverage for that. So how do we fill in to make sure that they have that? Then you would move to another area. You would, that way you could get the cost and decide which ones from the interim study would you recommend.
Right, but my concern is, first of all, we're asking for a study that we basically know the answer to already for all intent and purpose. There's a need, and there's, we don't know the exacts of it. So unless we do the recommendation as far as come back with the cost, we're kind of wasting some time, because they come back and say, okay, here's the parameter, here's the people, here's this and that, and then we go, okay, well, what's it going to cost? Then do we do another study, or are we going to incorporate it in there when we do the original one? Who decides the language?
Well, I don't know how to explain that. I will go back to the fact, gosh.
I'm all for it. I'm just saying.
I'm just trying to think. I don't know how many years ago we go back, but it's over 12 years ago when we started talking about we needed to have a dental director in this state. And we did like a short interim study to look at what areas we would need a dental director for. Based on that, we decided, yes, indeed, we needed to have it, and that's how we pursued the dental director. And we had directions of where they should be working within the state. So it just depends on what we put in the interim study that we want to look at. And then you'd have to look at that and say, what would that cost be to do that? And can the state afford to do that, or what else can we do?
Representative, I understand, I'm always frustrated like that too, but it certainly allows us to drill down and spend the money where it's identified. Once we find out a population or a group of people that need that service, we can certainly try to target the funding to address that service, if that helps any, or that particular population, if that helps any. But to me, it helps us sell it because now we've identified the need. I realize everybody in this room knows there's a need. Not everybody feels that way.
All right, thank you, Mr. Chairman.
Thank you. Further discussion? Representative Helmer.
I'm all for saving some money. I was a dental champ for 2 years in 2000, whatever, like 5-6 years ago. Tanya Dorf-Bruner, which maybe some of you remember, she was the chief of staff and director of legislative services.
You testified, yes.
She is still over dental champs, and she's Oral Health Kansas board of directors, and she's still over Dental Champions leadership group. And they have people that go all over Kansas, and that was what I did. I went over all over Kansas, and I worked with different populations. And we did dental clinics. We did all kinds of stuff and collected all kinds of dental data. So that would be a real good place to start off with, would be with Tanya. I knew that she did, and that was the one that I was trying to drive back. But she would be an excellent resource because that's what they do, is they work with people that need data, and dental health is what they do. Because what I learned is what you're talking about, the teeth drain down the esophagus and drain into the brain and drain, you have this huge cavity in the middle of your head, so it's draining into your ears, it's draining into your brain, it's draining into your heart. You get heart disease, you get, esophageal disease, you get stomach disease, you get all kinds of disease just because you don't take care of your teeth. And so that's what they're doing. So it's whole body health. So she would be an excellent person to start with. Thank you.
Further discussion, committee? We did get a second, did we not?
Yes, you seconded.
Okay. Thank you. All in favor, say aye.
Aye.
Opposed, same sign. Motion carries. Further committee recommendations? Okay, very good. Thank you, committee. Very good. We report out. We've had a little bit of with the scheduling and appropriations, but I will report this out next Wednesday, KDHE's budget. So with that, Matt, are you there?
Mr. Chair?
Yes. Okay, Matt, we're going to start the hearing on the Kansas Department of Aging and Disability. And Matt is going to give us a budget analysis for that agency. So you're up.
Certainly. Thank you, Mr. Chair. My name is Matthew Moore with Legislative Research. I'll be going over the Kansas Department for Aging and Disability Services. One thing that I will note is due to the governor's recommendation, including executive reorganization number 47, you will find that the items for KDADs for FY 2022 are located in the DCF budget analysis. So I will have to be referring to both the KDAD's budget analysis as well as the DCF budget analysis. We have tried our best to where KDAD's items are located in analysis to highlight that those are specific to KDAD's. And when I will have to jump from KDAD's budget analysis to DCF's, I will make sure to let you know and make it clear what page we'll be going to. But with that, I will begin with KDAD's, which starts on page 137. I will note that KDAD's is responsible for the Medicaid long-term care payments, surveys, certification of adult care homes, behavioral health programs, home and community-based services for older adults and persons with disabilities, as well as the management and oversight of the 4 state hospitals. Although the first few pages are just some history over the last several years of major items for KDAD's. If you turn to 148, you'll find a few performance measures. 149 is the kind of 10-year trend for the agency. And you'll see on page 150 our summary of operating budget table, which shows by program, by major category of expenditure, and then lastly by financing. But I'll begin in earnest on page 151 with FY 2021. So the agency requested a revised estimate of 2.2, including 135.1 million SGF for operating expenditures for 2021. This is an all funds increase of $75.8 million or 3.5%. The increase is primarily related to the receipt of coronavirus relief funds from the task force, of which at the time that the agency submitted its budget, they had included expending $58.8 million. You'll see when we get to the governor's recommendation, that does increase a little bit, but this is at the time that the agency submitted its budget. It had spent $58.8 million. We'll turn to page 152. I'll indicate that of those COVID money, about 23.6 million went to nursing facilities, 12.5 million went to a HCBS rate increase, and 12.5 million went to behavioral health. My understanding is those items were all for kind of rate increases that the agency received the money and it just kind of passed through and went to those entities. Again, those are based off of the time that the agency submitted its budget. Outside of COVID pandemic related transactions, the increase also includes implementation of the agency's administrative case management program. This was implemented late in, I believe, spring of 2020, which is designed to assist individuals in applying for the PD waiver, the frail elderly waiver, as well as the BI waiver. There's also included in that is a kind of a request of a one-time reallocation of reappropriations to fund the infrastructure for the electronic health record system for the 4 state hospitals. My understanding is that the 4 hospitals are kind of working on either very antiquated technology or no technology at all when it comes to electronic health management. So the agency took some reappropriations to establish that infrastructure at the 4 state hospitals. Also included is about $2.2 million to help for maintenance for that EHR system that will be an ongoing expense. There's a little bit of an increase due to the increased FMAP. As we've discussed several times in several different budgets, because the states received that 6.2% increase, that increased the amount of federal monies that were available and decreased the amount of state monies that the agency had to utilize. There is an increase of about 3 FTE positions for administering grants and programs for the Behavioral Health Commission and the Agency and Disability Services Commission. Lastly, the revised estimate also includes $18.5 million, all from the State Institution Building Fund for capital expenditures. This is an increase of 4.4 million, due in part to projects that were due to in 2020 being delayed into 2021. At the bottom of 152, you can see the governor recommended $2.3 billion, including 733 million SGF for operating expenditures. The increase is primarily due to, again, receiving federal COVID monies through the Spark Task Force that the agency received after it submitted its budget, that is included in the governor's recommendation. And my understanding is those funds that were received between that period went mostly to providing PPE equipment in nursing facilities. I'll note on page 153, the agency did request one supplemental for funding BI waiver services that did not make it into the governor's recommendation. My understanding is the agency anticipates growth in the BI waiver population due in part to that transition a few years ago from traumatic brain injuries to including acquired brain injuries, and they anticipate projected growth in that population. The supplemental was to try to help curb any sort of a wait list on that program, but that did not make it into the governor's recommendation. I'll note just on page 153 as well as 154 are the governor's allotments. Most of those items are related to things that were added by the 2020 legislature that then were removed, as well as some FMAP savings related to spring caseloads. And with that, I would stand for any questions for FY 2021, or I can continue on to FY 2022.
Questions? Seeing none, continue on to 2022.
I'll begin on page 155 with the agency's request for FY 2022. They requested $2.2 billion, including 884.3 million SGF for operating expenditures for FY 2022. This is an all funds decrease of $11 million. This is due primarily to the fact that those one-time COVID expenditures that we saw in FY 2021 are not continuing into 2022, which leaves a giant decrease between the 2 years. There are a few items that kind of offset that decrease that are primarily related to the EHR system continuing maintenance into FY 2022, as well as the agency's request to continue funding BI waiver services into 2022. So that supplemental from 2021 just continuing into 2022. There were a few enhancements for the PD and the IDD waiver to help kind of curb any sort of a growth in the wait list, as well as some expansion of IDD waiver employment services. And then several enhancements related to CMHC services being provided in nursing facilities, as well as behavioral health crisis hotline and a new program for homelessness prevention, which I'll go into here in a little bit more depth. I will note this is the point where I have to turn to the Department of Children and Families budget analysis, which KDAD's items will begin on page 91, and I can continue when everyone has had a chance to switch to DCF's budget analysis.
You find that? Representative Lynn has a question.
Certainly.
Thank you, Mr. Chair. I'm looking at the brain waiver funding. The supplemental funding for 21 was requesting 1.8 million from the SGF. And I see in 2022 I don't know if it wants to be fully funded or a reduction, or reducing the wait list, but I'm seeing that jumping to 8.7 million. If we funded it in 2021, do you know what that would do to the cost in '22?
Certainly. So part of that increase in 2022 is to continue that funding from 2021 over into 22. So those individuals that would have begun receiving services in 2021 would continue into 2022. And then any increase over the supplemental in 2021 is due to just the continued growth. I think the agency's estimate is about 4% a month growing. And so there's a little bit of growth there in 2021, and then the 2022 enhancement is to continue funding that supplemental, but then continue any sort of growth that it would see.
If I may, what's the current cost for, what are we spending right now for 21 for the brain injury? That's not the supplemental, but what's in the budget for 21 as it is?
Let me see, I can pull that up for you here just a second. So for the BI waiver right now, it appears the governor's recommendation is about 7.4 million SGF with an all funds of 20.8 million. And then in 22, it's 8.7 million SGF with an all funds of 21.7 million.
That's in the governor's budget, or that's the enhancement?
That's the governor's recommendation right now without the enhancement. So any sort of enhancement would have been on top of that because the governor didn't recommend those enhancements. The governor's recommendation is just what we're spending right now.
That's what I meant, but this is an agency request. It's the same, it's not in the governor's budget.
Yes, the enhancement is not in the governor's recommendation.
Okay.
Okay, thank you, Mr. Chair. I just want to be able to say that I think we really want to not have a wait list for brain injury, if possible, just because as a brain is injured, it loses its plasticity and its ability to heal. So I just don't think it's a good idea to allow people to go on a wait list.
Sure.
Thank you.
I think we're going to have plenty of time to discuss that. Just for clarification, the agency requested the money and the governor did not put it in her budget. So that's where we're at. Representative Ballard.
I think all of that is true. You know, we've not had a wait list for brain injury. And we also know it's that one of the only waivers that we have, that if you catch it early enough, they can rehabilitate, they come off of the waiver. Most of the waivers, we have physical disability waiver will be the same way, but we have other waivers when people get on, they stay on for years and years and years. But with brain, if you can just do it early, you can get them off and they go on. Now, was it 2 years ago that we changed the category between acquired and traumatic and the other? And so therefore, we picked up a larger population of people that were not being covered in the state before, because we have the two categories. That is why we really have a wait list now for the first time, because we have added so many more people to that. And yet, it was mentioned that if we increased it, obviously, we'd be covering more people, and we were going to have more funding for that as well. So the realization happened. That's exactly what happened. And I'm agreeing with Representative Lynn that everyone else, I think, on this committee would agree. You can't have a waiting list if you're trying to rehabilitate these people, get them off, and they become productive citizens. And so that's what we're up against right now.
Very good. I just might add, in 2015, we had folks on that waiver that were costing us $1 million a year. $1 million a year for their care. So if that could have been prevented by early intervention, think about how much money we would save. So anyway, this is food for thought for when we work the budget and recommendations and stuff like. Matt, sorry we got a little bit off, but we did need to cover that. Continue on.
So I'll be continuing on page 91 of the DCF budget. You can see that the governor recommends $3.1 billion, including $1.3 billion SGF for 2022 expenditures. That's an increase of $2.4 billion above what the agency requested. And so that $2.4 billion is that shift from taking DCF and adding it into KDADS. Now, what that would look like over KDAD's request is approximately an increase of about 150 million over what KDAD's requested. And if you'll turn to page 92, you'll see that's primarily related to fluctuations in human services consensus caseloads. As part of the acquiring that temporary increase of 6.2%, there's the restriction that we're not able to remove people from the Medicaid rolls. And so there's an increased population of individuals who are eligible for Medicaid that kind of continue into 22, which is what's driving that kind of dramatic shift upwards. Other than that, there are a few enhancements that I'll go over that were included. But that primary increase is due to kind of an increased Medicaid population. If you'll turn to page 93, you'll see 2 enhancements. The last 10 items are KDADs, and you'll see the KDADs enhancements there about halfway through the table. You'll see that the governor recommended the maintenance for the electronic health records, the CMHC specialized services at nursing facilities for mental health, as well as the $5 million for the statewide mobile response. That's the 988 hotline, and then approximately $580,000 for the community integration housing first program. That's that program to help kind of prevent homelessness, as well as an FTE to function as a coordinator for that position. And then there'll just be more detail on those enhancements starting on page 94. You'll see at the very bottom enhancements requested by KDADS, and that goes all the way to page 97. And then I'll just briefly touch upon reduced resources on page 98. The agency did submit several reduced resources when they were requested. A majority of those dealt with reductions in reimbursement rates for waiver services, for PACE, for PRTF, ICFs, a lot of those sorts of programs, just reducing the reimbursement rate. The governor did not include any of those reductions in her recommendation. The 2 that were included are some savings with the administrative case management program, because that was implemented late in fiscal year 22 in 20. That's still kind of growing. The agency was receiving a appropriation for that program, I think of maybe $6 million, and they were only left over about $3 million SGF that the agency said, well, you know what, since we're not going to be utilizing that, we'll give that up as our reduced resource. And then the governor accepted that amount. The other item is a 10% reduction in the nutritional programs of $850,000. Those are going to be, Meals on Wheels, providing meals in a congregate setting for individuals. My understanding is that while that is included in the governor's recommendation, that the agency does believe that there might be some leftover coronavirus relief funds that will kind of carry over into 22 that they might be able to utilize to help offset any sort of a reduction for FY22. But those are the only 2 reduced resource package items that were adopted. And you can see more depth and more narrative on the following pages all the way to 104. With that, I can stand for any questions on FY22.
Good. Committee questions? Very good. Seeing none, Matt, thank you. Thank you for the Representative Concanon. You better get moving.
Can't see.
Hang on. We've got Representative Concanon has a question here.
Raising my hand but not being vocal. Matt, I'm not sure that I know what, I guess I don't know what I don't know. But I asked about the electronic health records a week ago, and I'm still not clear on the timeline, and I'd like to understand it. I'm not questioning that anything's wrong. I'd just like to understand. And they're requesting $2 million SGF for support and maintenance of the state, the new electronic health records. So is that just support and maintenance, $2 million? Or is that partially paying for the new system? I don't know. I'm just kind of confused by that whole thing and the fact that we have one state hospital that's still not using electronic medical records and the other three are a DOS-based system. Just wanted to say that out loud.
Certainly, and I can clarify that. So in FY 2021, the agency was able to find kind of reallocated reappropriations to establish the electronic health system and provide for some maintenance of that system. So the actual creation and installation of that would be occurring in FY 2021. I believe the total amount for that is approximately $9 million. 7 of that being the infrastructure, changing cables and things at the hospitals to help establish that system. And then the $2 million that you see, and then there's another $2 million just for the maintenance of that system. And then that's what you see again in 22. And why it appears is because that'll be ongoing maintenance at the state hospitals to keep that system kind of up and running, that would be added to the base budget and continue on into the future.
Very good. Committee, further questions? Well, you did a good job there, Matt. Thank you. Okay. Who's on board from the agency to talk us through the rest of this?
Mr. Chairman, it's Secretary Howard. I'm here.
Secretary Howard, very good. Welcome to committee, and thank you for being here.
Several of my team members that I can use if I need to use a lifeline or phone a friend for any answers to questions. So you've got my presentation in front of you, and I think Scott's put it up on the screen. There's a lot of slides here, so I'm going to try to focus on those things most relevant to your budget discussions. But there are some areas where I think it's just important to give the committee some updates from what has happened last year. So I think that'll be very important. So the presentation starts with just a quick overview of the KDAD's program areas. I won't spend a lot of time on those. The first is administration. I mean, as it relates to the budget, on the next page of the slides, normal administration functions. Then we also have the Survey, Certification and Credentialing Commission. And this is the commission, of course, that inspects and licenses adult care homes, as well as providers of a number of disability and behavioral health services. We have field staff across the state that do this work every day. The next major program commission is our Aging and Disability Community Services and Programs Commission. And this is where you see the community-based programs for folks who are aging or individuals with disabilities, with IDD, with physical disabilities. This is where also the Older Americans Act programs flow through. Next, from a budgetary perspective, are the Medicaid pieces connected to KDADS. That includes everything from nursing home reimbursement, the PACE program that you heard about earlier this year, and the 7 home and community-based services waivers that we manage. As well as the behavioral health services, those mental health and addiction services that are supported through Medicaid. We also have a behavioral health services commission that includes, services for mental health and substance use disorders. We contract with community mental health centers and others for those services. On both the mental health and substance use disorder side. And a lot of activity going on within that commission. Well, really within all the commissions, but I think some important pieces there. And then the State Hospital Commission, when we spoke with you last year, I think we had just done some reorganizing to create a focused State Hospital Commission. So that's just a little bit about our structure. I did want to touch on some key priority issues. I'll start on page 11 with regard to nursing facility receiverships. As many of you know, KDADS did take 22 adult care homes into receivership due to insolvency a few years ago. And last year, we put some legislation through related to the receivership statute based on learnings from that situation. I'm really pleased to be able to tell the committee that, one facility had closed in 2018. Since that time, every other facility in receivership except for one have now been sold to new providers and remain operational with residents. So we have one facility that remains from those receiverships. It's been a lot of hard work to get there from ourselves and some contracting partners, but I think really good outcomes for Kansas seniors. Next, I might just touch on survey and certification. It's been I think the piece I would focus on here, there's a lot of bullet points on the slide, but this has obviously been a very busy year for our survey and certification staff during COVID. We follow and really do our work at the behest of the Federal Center for Medicare and Medicaid Services. And after initially kind of standing down surveyors when COVID hit about a year ago, the work became very active. And across the country, survey teams were directed to complete infection control surveys at each adult care home, focusing on infection control policies, which we did and completed. And then subsequent to that, the level of our survey activity has really, until recently, been driven by the number of new COVID cases, issues of complaints and things like that. So it's been a very, very busy time for that team. That team also was responsible for creating the PPE protective equipment portal through which adult care homes could purchase PPE. And so I would just highlight those couple of pieces there. Within the aging and community services area, again, it's been a busy year, even in the context of COVID. We've received approval by CMS of 5-year renewals for the physical disability and feral elderly waivers. The federal money follows the person program has been reauthorized. And then an activity that has been very, very time consuming and focused, really, really important work is ensuring that providers are coming into compliance with what's called the federal final settings rule. It really has to do with ensuring that individuals are receiving services and supports in the most integrated setting possible, that we're really kind of living out the promise of true community-based living. So again, that's been an ongoing process. Those of you on this committee in the past have heard about that each year. We've already mentioned the administrative case management services that launched. That's going very well and beginning to grow, and we're very, very pleased about that. And then maybe one thing many folks don't know about KDADS is that we also assist individuals with their applications for Medicare Part D, and have assisted more than 30,000 individuals with that process. I wanted to take just a minute with regard to the Aging and Community Services Program and touch on the brain injury waiver. And again, you've kind of already keyed into that. I think a really critical, important issue. Just a reminder, the legislature in the 2018 session, recommended and directed that the waiver, which had been a traumatic brain injury waiver, be expanded to include acquired brain injury and also be expanded to include children. It had previously just been an adult waiver. So this really expanded the waiver from a waiver serving folks, from accidents, different kinds of traumatic brain injuries, to individuals who might have a stroke or another neurological issue that leads to an acquired brain injury. It took quite a bit of time, and I think we talked to you last year when the last session started. We had just begun to implement the expansion of the waiver. And I think if I move you to the next slide on page 15, you can begin to see the growth that's begun to take place in the waiver. On slide 15. There we go. So at this point, at only 7 months in our current fiscal year, the waivers are already serving more individuals than the approved waiver would authorize. And if the growth continues at its current rate, without policy changes or implementing a wait list, will far exceed the budgeted capacity of the program. And we put some of that data on the following slide. I think you were talking about numbers a little bit earlier in the current appropriations, and those are on the next slide on slide 16. So our estimates that we included in our supplemental and enhancement requests are that the all funds cost of the waiver will be close to $26 million in the current year, all funds, about $5 million more than the current appropriation, and that would be about $21 million more in the out year. And again, the SGF dollars are less than that, a little over $1 million in the current year, about $8.7 million in state fiscal year 22. We are doing some work on the policy side related to this waiver, and we've detailed that a little bit on slide 17. In fact, we had a work group this week with some stakeholders who have come to the table with us, with KDHE, with MCO representation, some of our providers, and some of our consumers, to say, how can we really ensure that that this waiver really retains a focus on being a rehabilitation waiver? I think, as folks indicated earlier, clearly with the rehabilitation waiver, our preference would be to not have to move to a waiting list. It is important that people receive services as early as possible on this particular waiver. But we are doing some particular work through this policy group to really ensure that we have the right policies in place to make sure that folks who come on to the waiver receive what they need on the waiver, remain on the waiver while they're continuing to make progress towards their individual goals, but then transition off of that into whatever services or greater independence that they might achieve at that time. And as we look at the data, and we found some, most folks are on the waiver a couple years, but we do have some folks who've been on many, many years. And so I do think that in the context of the waiver, we do have some work to do on the policy side that we commit to making sure takes place to ensure that that rehabilitation nature of that waiver continues. So I would just add that piece as an important component in addition to the issue of the overall funding level for the waiver. Let's see, on the next page, I'll shift over and again talk just briefly about the nutrition program. These are the grants that go out to the area agencies on aging to provide nutrition services either in home or in congregate settings. And we combine a number of different revenues with that funding. The budget does propose for fiscal year 22 an $850,000 reduction. And we're getting a lot of COVID funding for nutrition, and I'll show you a chart related to that a little bit later in the presentation. We believe that that level of funding in the current year will allow us to carry forward at least $850,000 of the state's annual allocation to offset this reduction and not lead to any reduction in meals. I'd next like to highlight a few items within the behavioral health part of KDADS. You can see on the first slide kind of an array of items. I think we're really proud of the peer support programs that we've put in place. Some of the work that we've been doing with partners around suicide prevention, with in terms of some of our community of practice work, our statewide suicide prevention coalition. And there's a couple of other things on here I'll talk about when I go to another slide, because I think it's important to spend a little bit more time on them. 988, as well as the Hayes Children's Beds. So I might move on then to the next slide. PRTFs, I think this has been a topic we've been talking about. Well, at least I've been talking about. This will be the third year. We've made, I feel really proud of the work my team and partners have done in this area. The wait list continues to go down for admissions. And I just wanted to highlight for this group that since about this time last year, we've been able to increase the number of licensed PRTF beds by 100. So 412 beds in the system of care now, up from 316 this time last year. So again, about a 33% increase in bed capacity in the last year. And there's also going to be a new 12-bed PRTF licensed in April by Ember Hope in Newton. So a lot of work there to really looking at those needs for those youth. So again, we're really, really proud of the work that's been done to increase those services. I might next talk briefly about our crisis stabilization units. You might recall these are the units that are really being funded through revenue from the lottery vending machine program. A few years ago, when these programs first started, there were some state general fund appropriations that started some of the larger programs in Kansas City, at RSI, in Sedgwick County, and in Topeka. We have been able, through this funding, to expand to programs in Hayes, Lawrence, and Manhattan. It's an interesting thing during the pandemic. We've actually seen some increases in the vending machine estimates. I think maybe when some other things were closed, people could still go to those vending machines. And so we believe the level of funding from that resource will allow us to cover additional expansion next year in 3 more communities. And I think where we've seen the most interest and maybe the most readiness and community collaboration with community resources also coming to the table are Leavenworth and Pittsburgh. And then we're also looking at possible expansion for a children's crisis unit in Topeka. So again, those three are tentative, but those are certainly the locations that we think have the most readiness going into fiscal year 22. And again, these are really, really important parts of the continuum of care and assuring that services are available in the community. On the next page, I just wanted to highlight a brand new initiative that we're very, very proud of. This is a partnership with the Council of State Governments Justice Center, and it's called the Stepping Up Initiative. And Stepping Up is really a program that's about improving the outcomes for people with mental illness and co-occurring substance use disorders in jails. You might recall there was an LPA report a few years ago that really talked about what a tremendous stressor mental illness and substance abuse was having on our jails. So we've partnered with CSG, and we just announced last week a Stepping Up Initiative Technical Assistance Center that CSG is supporting. And so this will be the second Stepping Up TA center in the nation. Pennsylvania was first, Kansas will be second. I think just, again, really, really important in terms of helping counties to work towards how they can reduce the number of people with mental illness and substance use disorders in jails. So again, we're really proud of that initiative and opportunity. Let's see, on the next page, I just wanted to just briefly mention, and I think you'll hear this from other conferees when you have public testimony, are the concept of certified community behavioral health clinics. Certified community behavioral health clinics started out a few years ago through a limited federal opportunity through what was called the Excellence in Mental Health Act that allowed a few states to apply for what I think of is similar to FQHC services on the behavioral health side, providing prospective payments, expecting broader comprehensive services. Those were pretty limited opportunities, and the door was pretty closed to states that didn't get in on that. And unfortunately, many of our neighboring states did, which is, I think, had a significant impact on our behavioral health workforce challenges. But just recently, 6 Kansas community mental health centers have received a 2-year expansion grants from SAMHSA to help prepare them to meet the requirements of being certified community behavioral health clinics. And again, we could spend an hour on this topic, but there is some legislation in the legislature this year. The House bill is 2160. I think it's on general orders related to the possibility of creating this type of an entity within Kansas. Next slide, I wanted to talk about on slide 24, mobile crisis response. This is one of the enhancements that the governor has recommended. You'll recall a few days ago when I talked about the DCF budget, we talked about the fact that the governor had recommended $3 million in the DCF budget for statewide mobile response for youth having a behavioral health crisis. And in fact, we were able to start that program with some one-time federal grant funding, and actually just this week announced a partner for that program. The governor also has recommended, as Matt said, $5 million as an enhancement in the KDAD's budget for mobile crisis response. And again, I think a really, really important part of the continuum of care in terms of having the ability to respond when folks are in a behavioral health crisis with behavioral health professionals. And there's several slides in here that connect to just the value of mobile crisis and how it fits with other initiatives. initiatives. This references how it fits with CCBHCs because the CCBHC model would require these crisis services. The next slide talks about how mobile crisis response fits with 988. And for those of you who may not be aware, 988 will be a new national 3-digit number that essentially replaces the existing numbers for suicide hotlines across the country. So essentially, it's a mental health 911 number. States have to implement this beginning in July of 2022. And that number will be live no matter what happens between now and then. And so I think about mobile crisis response connected to that in the sense that if you call 911 now, and if you need something more than talking to that operator, an ambulance comes out. With 988, if you call that behavioral health crisis line, the fact that we would have mobile crisis in place means that there's a response outside of law enforcement or EMS dispatch in circumstances where that mobile crisis response would be most relevant. So again, I think a really, really important part of the continuum, and I think even more important because of the increased numbers of calls that we clearly believe those lines will get with the implementation of the 988 number. So I would certainly ask you to support the governor's enhancement there for that funding. Couple more things on behavioral health on the next slide. Crisis intervention centers. We've been talking about these for a couple of years. I think first, just to context this again for the committee, these differ from other parts of the crisis service array because they would allow for involuntary patients to be held in those crisis intervention center facilities. It has taken us a long time, longer than I would have liked, to be able to promulgate regulations in accordance with the legislation that was passed a few years ago. But we're in the final stages, and we should be licensing crisis intervention centers later this year. And frankly, the first ones will likely be at the some of the existing crisis stabilization units that I talked about, probably first in Kansas City and Wichita, maybe Topeka, maybe Lawrence, and then I think there are some others that are perhaps interested in looking at independent facilities. But again, really, really good progress there. I'm going to skip over to 2 pages ahead to slide 28 and talk just briefly about state institution alternatives. When we were in front of you last year, the governor recommended and you supported funding for what we talked about as regional beds. And this is very much a part of the ability to lift the moratorium at Osawatomie and provide services closer to home. We've been working over the last several months to hone that concept. And we've actually created, working with our Medicaid partners, a provider type now called State Institution Alternative. And this would allow private psychiatric hospitals to enroll in Medicaid, be reimbursed on a per diem rate for any patients that have been successfully screened for state hospital admission, and as well as to receive state funds for the care of the uninsured. So I just partly just wanted to get that concept in your head. We've kind of changed our terminology a little bit from regional beds to, you'll hear SIA quite a bit. But this is really the modality to provide those regional alternatives. We have just had our first provider come into that program. That's Prairie View and Newton, and I'll say a little bit more about that a little bit later in the presentation when I give some updates from the last session. But again, we're excited about that, excited about having additional providers come into that program. I'm going to skip a few pages here because you've already talked about, you've done state hospitals. We don't need to talk about the ERO. So I'm going to skip over specifically to slide 32, which again, just kind of building on what I was just talking about, the regional beds. You'll recall this was originally a $5 million addition last year. Half of it was reduced in the allotment, but with the Osawatomie diversion funds, if it already been in the budget, we have about $6.4 million towards those state institution alternatives. And so again, we've done several things. Again, first of all, Prairie View, and that should say in Newton, is really our first adult provider. KVC is also enrolled from the children's side of the equation. We've also executed amendments to our current contract with Health Source Integrated Solutions, who will be helping to manage this in the same way that they help to manage that they've been helping to manage our OSH diversion. And we've released an RFP for management of these funds for the next 5 years. So a lot of activity there, and we'll be working hard to get some additional providers on board as well. Next page, I think another important update on the children's acute psychiatric beds in Hayes. The RFP for that is on the street and actually closes tomorrow. So it's our hope that we'll be able to make some announcement about that, hopefully by the end of March or early April. I would note as part of that process, we also gave bidders the opportunity to also include any plans to offer any regional beds for adults through the SIA program or crisis stabilization services as well, should there be any benefit to them, combining a number of services in the Hayes area. So again, as you think about some of the stressors and pressures on our state hospitals, all of these pieces are really those critical components. A couple more. I think when you talked about the state hospitals, you already talked about the plans at Osawatomie with regard to the Biddle remodeling. And again, we continue to be in the design phase for the remodeling of the East Unit. We expect construction to begin in the fall. And then the last addition it relates to the electronic health records infrastructure. As you recall, last year, KDADS had identified about $7 million in prior year reappropriations that we could use to actually bring on an electronic health record system. But because of the nature of our state hospital buildings, there needed to be some core infrastructure work done to support the new system. So, basic things like updating telecommunications equipment and switches to even just be able to accommodate a new electronic health record system. So there's been a lot of work done already with receiving some of that equipment, and will be an RFP about updating fiber optic services and wireless networks. And I think we're also very close on the electronic health record side. We should be issuing the RFP for the actual purchase of that system by the end of February or early March, just to give you a status on that. The next few pages just give some pictures of the KDADS budget. I think I'll skip the FY21 pages, really to not be repetitive about that, and move over to page 42. It's not going to look very much different between the 2 years, but again, just a context for the KDADS budget. About $2.4 billion, almost 60% of that coming from federal funding sources. Just that overall context. And if you look at the next page, 91% really connected to what we talked about as the Medicaid program, nursing facilities, the 7H CVS waivers, the Medicaid that's within mental health and substance use. So you can really see how heavily of a Medicaid agency that we are. And then I might skip over just to page 45 on the federal fund side, just again to give you a context. Again, significant funding from the Medicaid program, but also really important funding from some targeted other federal resources. The Older Americans Act that funds so many of those senior services, and our mental health and substance use block grants that you can see in there as well. So again, just a context piece. I'm gonna skip over to page 48, and again, just to reiterate what Matt said, no supplementals were added in our FY21 budget. The only changes in the budget had to do with consensus caseload and particularly some of those FMAP changes that took place. All right, just for information, we've included just some basic information on caseloads in kind of the next couple of slides, not just for the Medicaid programs, the waiver programs, but also some basic information about nursing facilities, nutrition programs, Senior Care Act. I'm happy to answer any questions about that, but I won't take time today to go over that in detail. Then page 51, as Matt indicated, the governor's recommended 4 enhancements in our budget that I would ask your support for, in addition to the consensus caseload changes. The first of those changes, the first enhancement, we've already talked a lot about on the next page, the statewide mobile response and stabilization. Again, $5 million state general fund. Really, really important part of the continuum of care. I already talked about the ways in which that links so directly to 988, to the concept of CCBHCs, to just really providing better health outcomes and reducing some of that multi-system involvement, whether that's other agencies, whether that's law enforcement and the like. So again, I would ask your support there. The governor's also recommended funding related to housing, the concept of housing first. And this funding would allow us to serve uninsured homeless or those at risk of homelessness with disabilities as they reintegrate into the community from institutional settings. And again, much of this is, I mean, this has long been needed. I think one of my reflections as I came into this role a couple of years ago was how much more work we really needed to be doing as a state in both supported housing and supported employment. I think we talked to you about a pilot that had taken place a couple of years ago, last year, that had really good outcomes. This would allow us to make a little bit of additional progress with about $500,000 all funds for the program and 1 staff position. So again, I would ask your support there. The third item, I think you've talked about that already. I've also talked about this. When we were in front of you last year talking about the electronic health records, we did indicate that there would be ongoing support and maintenance costs across the 4 state hospitals, that those would equate to about $2 million a year. So while we found the resources to deal with some of the infrastructure pieces and to actually purchase the system this year, that there would be ongoing added costs. And again, the governor has recommended those funds be put into our base budget, and we would ask your support for that. And then the last item included in the governor's recommendation is $2 million from the state general fund to allow us to provide specialized services to Kansans that are in the 10 nursing facilities for mental health across the state. I think this is a very, very important initiative as we think about the concept of community integration, as we think about the Olmsted decision and really supporting the most integrated care for individuals. You know, Kansas is a really unique state in having these 10 specialized NFMHs. There actually used to be 21 of those that I can remember many years ago. So there's an effort over time to ensure some work was done to really ensure informed choice. But this funding, it really is required to meet new federal law and regulations for specialized services under pre-admission screening requirements that we do. This has been an important recommendation from the Mental Health Task Force for a number of years as well. But this would allow services such as intensive case management, some vocational or supported employment, community day integration opportunities. And again, the whole focus here is ensuring that as individuals go into nurse facilities for mental health, they're receiving those specialized services and they're having the best possible chance of discharging to the most integrated setting. Last thing I would talk about, Mr. Chairman, goes back to the COVID. We've given you a couple of slides. And let me context this. Think about this as kind of two sets of funding. The first slide is really about the funding connected to the SPARK process, the funding that came directly to the state as a whole from the CARES Act. And so KDAD's through that internal state process received and distributed about $81 million. 34 million of that was in a direct payment to nursing facilities, really our skilled nursing facilities, to provide them resources for their purchase of PPE and testing supplies. About 8.9 million to an array of community-based providers, also including within that some PPE and communication devices. There's been a little under $20 million to behavioral health providers, again, meeting those specific COVID costs, maybe some technology needs, but also some revenue replacement as well. And then 18.9 million to adult care homes. You know, those facilities that are not our skilled nursing facilities. This is where the portal we stood up fits in. We also provided communication devices and equipment like plexiglass dividers, things like that, to support different types of visitation. You know, a few months ago when the weather was a little bit warmer, you know, facilities could, you know, they could have purchased things, for example, to put tents outside or things like that. And then a small amount for some administrative equipment related to our own ability to telework. So about $81 million from the funding that came to the state as a whole that went through the SPARK CARES process and was reviewed and approved by the legislative committee. The next page, though, is funding that came directly to KDADs from our federal partners. There were a number of lines of funding in the CARES Act, particularly from the Older Americans Act and through SAMHSA, that was targeted directly to agencies like ours for services. So you can see the largest items there are the services to provide congregate and home delivered meals. We've received about $7.5 million for congregate delivered meals. And I would just give our aging partners in the community so much credit. When all those congregate sites had to close, they really stepped up with lots of innovation in those communities to kind of keep meals going for seniors, and have done some really, really innovative things. There's some other Older Americans Act pieces related to other pieces of in-home and community-based services, a little bit of additional funding for the long-term care ombudsman office, some things like that. But the other largest amount is we received some emergency grants from SAMHSA targeted specifically to mental health and substance use. And those have really been targeted to CMHCs in the areas most directly impacted by COVID. And again, they're doing, this is really an entire array of direct service functions that they're providing within those communities to impacted individuals. And just in kind of full disclosure, we also will be receiving more funding that's not reflected here yet, that I think is important to let you know about. In the very last bill that passed federally, the Consolidated Appropriations Act, as I think it's called a couple of different things, but that last budget reconciliation bill that they did at the end of last year includes, we don't know for sure how much, but somewhere between 20 and 40 million in primarily additional behavioral health dollars that will come in through the mental health and substance abuse block grants. We're waiting for information from our federal partners as to what kinds of streams requirements might be on that. But in the meantime, we're working closely with the Recovery Office and some of the consultants that they have on board to begin to identify possible uses of those resources. So again, more to come on that. I'll certainly commit to keeping this committee and the legislature up to date as we learn more about what those possibilities might be. I think the last couple of pages of the document were the reduced resources. I think I've really talked to those, I think have been talked about already. The senior nutrition, that we believe we have sufficient resources. The administrative case management, I think Matt did a great job of talking about that. Just based on the current level of growth, we think we really have some one-time savings in fiscal year 22 that we can offer up without having a service impact. So thank you, Mr. Chairman. And I think the last page just listed the allotments from last year. So
Correct.
I know that was a lot.
Yeah. I think what we might do tomorrow is, if you guys have time, if you could come back at the beginning of our meeting, and we might have a few questions as we digest this.
Happy to do that.
Would that be okay, committee? Because I know this is a lot, and you just mark it up and get your questions ready, and we'll spend whatever time we need tomorrow, and then we'll start, and we will have, so very good, Secretary. Thank you.
Thank you.
For the updates and all the information. And committee, we will have a public testimony on this budget, KDAD's budget, tomorrow. And but at the first of the meeting, we'll have a question and answer session. Yes. Okay, very good. Thank you. Thank you for being here. Thanks, everybody that's online for